You know, when you first study the protocols for treating early-stage cancer, the whole approach feels remarkably similar to reading a tactical manual for a local house fire.
Right. Yeah. You find the source, you contain it, and you just extinguish it.
Exactly. I mean, the therapy is incredibly aggressive, but the problem is entirely localized.
The boundaries are clear. So the entire clinical objective there is total eradication. It's like a sprint, and you are throwing every ounce of water you have at that one specific room to make sure the fire never comes back.
But then, you turn the page to metastatic breast cancer, and the entire rule book just flies out the window. The embers have already scattered into the surrounding forest.
You aren't fighting a single localized fire anymore.
No, you're not. And if you're a medical student prepping for the wards, maybe a young clinical professional, or just a dedicated self-taught learner trying to grasp the realities of advanced oncology, you have to realize that this requires a fundamental shift in your strategic thinking.
It really is the ultimate paradigm shift in clinical oncology. The terrain you are fighting on, the timeline you are working with, and, the ultimate objectives of care fundamentally transform.
And that is exactly what we are unpacking today. We're doing a deep dive into a masterclass of a resource. It's called 100 Questions and Answers about Advanced and Metastatic Breast Cancer.
Yeah, that's authored by Lily D. Shockney, a University Distinguished Service Assistant Professor of Breast Cancer at Johns Hopkins, and Dr. Gary R. Shapiro, who is the chairman of the Department of Oncology at Johns Hopkins Bayview Medical Center.
Such a great source. We're going to dig into the diagnosis, the treatment pathways, symptom management, and end-of-life care. But more importantly, we're looking at the biological mechanisms driving those clinical decisions.
Because we really need to look at the why and the how. I mean, memorizing clinical protocols is one thing, but understanding the underlying cellular logic is what actually allows a clinician to navigate the immense complexities here.
Okay, let's unpack this. Let's start right at the moment of diagnosis. We are talking about stage 4 or metastatic breast cancer, which you'll see as MBC.
Right. Meaning the cancer has spread outside the breast tissue and the regional lymph nodes to distant organs, most commonly, the liver, lungs, bones, or the brain.
But you mentioned a paradigm shift earlier, because a lot of people still view a stage 4 diagnosis as an immediate acute death sentence.
And historically, that was the grim reality. But modern oncology approaches MBC much more like a severe chronic illness.
Like diabetes.
Exactly. Think about how we manage type 1 diabetes. If a diabetic stops taking insulin, the disease becomes fatal very quickly. But with continuous managed intervention, they can live for decades.
Oh, wow. So MBC operates on a similar clinical philosophy then?
It does. You are administering regular systemic treatments to keep the tumor burden controlled. The objective shifts away from a curative sprint and becomes a marathon of disease control and quality of life.
That actually brings up a fascinating clinical protocol that I think surprises a lot of people.
Oh, about the biopsies.
Yeah. So a patient comes in, they have a history of breast cancer, and a new scan shows a lesion on their liver. The immediate next step is almost always an invasive biopsy of that liver lesion.
Right.
If we already know the patient has breast cancer, why put them through a needle biopsy just to confirm what we already see on the scan?
Well, because you are assuming the cancer that landed in the liver is genetically identical to the cancer that left the breast. And biologically, that is often a very dangerous assumption.
Because it mutates.
Relentlessly. When cancer cells migrate, survive in the bloodstream, and colonize a distant organ, they undergo significant mutations. The receptor profile of the original primary tumor can completely change.
So wait, a tumor that was feeding on estrogen in the breast might metastasize and suddenly become hormone receptor negative in the liver?
Absolutely. Or its HER2 expression might flip. Right. So if a clinician skips the rebiopsy and just assumes the pathology matches the original tumor from, 5 years ago, they might prescribe a highly targeted therapy that is now completely useless against this new metastatic colony.
That is wild. That makes the pathology report the absolute compass for the entire treatment strategy.
It does.
It's also why you see the term FISH testing on so many of these charts. Yeah. We hear about FISH all the time, but let's break down what that actually looks like in the lab for the listeners.
Sure. So FISH stands for fluorescence in situ hybridization. It is just a brilliant piece of molecular diagnostics. Pathologists use specialized fluorescent probes that bind only to specific genetic anomalies.
Like an amplification of the HER2 gene, right?
Exactly. When you look at the sample under a fluorescence microscope, those specific cancer-driving genes literally light up.
That's incredible.
It allows the pathologist to physically count the overexpressed genes and tell the medical oncologist exactly what they're up against.
which is why the multidisciplinary tumor board is non-negotiable. You need that specialized breast pathologist looking at the Fairshade results, coordinating with the medical oncologist and the radiation oncologist.
You absolutely need that entire team aligned.
But let me push back on something from a patient's perspective here. If catching these metastases and mapping their biology is so critical, why do we wait for a patient to complain of bone pain or shortness of breath?
The surveillance question.
Yeah, because if I'm a patient, I want a full-body MRI every single month to catch microscopic spread before it becomes a problem.
I know, and it feels incredibly counterintuitive. The urge to constantly survey is deeply human. But clinical trials have consistently demonstrated that performing routine asymptomatic scans on early-stage survivors offers absolutely zero improvement in overall survival.
Wait, not at all.
None. Zero. What it does do, however, is generate devastating psychological distress and physical harm through false positives.
Ah, right, because scans pick up everything.
Exactly. They pick up benign cysts, scar tissue, or just shadows that mandate invasive, risky biopsies, only to turn out to be nothing. Furthermore, our current imaging technology simply cannot detect microscopic cellular clusters anyway.
So standard clinical practice relies on symptomatic triggers instead.
Yeah.
Like persistent localized pain that doesn't resolve, or sudden neurological changes.
Right, those are the triggers to initiate targeted imaging.
So more data isn't always better data. It's really about acting on actionable clinical triggers. So let's pivot to the pharmacological arsenal once those triggers pull us into treatment.
The critical distinction here is moving from local therapy to systemic therapy.
Right, because local control has a very specific, limited role in stage 4 disease, right?
Yeah, if a patient has a single, excruciatingly painful metastatic lesion on their thoracic spine, a radiation oncologist can target that one specific spot to shrink the tumor and relieve the pressure on the nerve.
Or a neurosurgeon might excise a solitary brain metastasis.
Exactly. But that does nothing for the cancer cells freely circulating in the bloodstream.
You can't radiate the entire circulatory system. You need therapies that travel everywhere the blood goes.
Systemic therapies.
Right. And it's a tumor pathology, proven by that rebiopsy we talked about, shows that the cancer is estrogen or progesterone receptor positive. Hormonal therapy is often the first line of defense.
It is.
But I was reading through the protocols and I got a bit tripped up on the menopause distinction.
Oh, the pre- versus postmenopausal pathways.
Yeah. So for premenopausal women, you shut down the ovaries, either medically or surgically. That makes sense to me, as the ovaries are the primary estrogen factories. But if a postmenopausal patient's ovaries have already permanently shut down, where is the estrogen coming from that the tumor is feeding on?
That is a great question. The ovaries aren't the only source of estrogen, they're just the loudest. In postmenopausal women, the body still synthesizes estrogen in adipose, or fat, tissue, and in muscle.
Really? How?
It happens through an enzyme called aromatase. It basically converts circulating androgens into estrogen.
Ah, so the fuel source just relocates.
It does, and that changes the entire pharmacological approach. So instead of targeting the ovaries, we use aromatase inhibitors, or AIs, like anastrozole.
And those circulate systemically.
Yeah, they circulate systemically and block that specific enzyme, effectively starving the tumor of its estrogen supply. But there is a massive biological trade-off.
What's the trade-off?
Estrogen is critical for maintaining bone architecture. By chemically depleting the body's remaining estrogen, AIs accelerate bone resorption.
Creating a massive risk for drug-induced osteoporosis.
Exactly. You are essentially forcing the skeleton to weaken. So clinicians must actively monitor these patients with regular DEXA bone density scans.
I mean, you don't just watch the bone degrade, obviously. You intervene with bisphosphonates, right? Like intravenous zoledronic acid.
Right, which actively inhibit the osteoclast cells that break down bone tissue.
It is just a constant game of biochemical chess. You block the estrogen, protect the bone, and monitor the tumor.
It really is.
But what if the tumor isn't relying on hormones? Like, what if the Fish test lights up like a Christmas tree for HER2 receptors?
Then you move to targeted therapies. The biology of HER2 is fascinating. It's a protein receptor that sits on the surface of the cell and basically acts as an antenna, constantly shouting, divide, grow.
And that's where trastuzumab comes in, right? Most people know it as Herceptin.
Yes. It is a monoclonal antibody engineered to specifically bind to the outside of that HER2 receptor, jamming the signal.
But what happens if the tumor mutates and that drug stops working?
Then you pivot to a drug like lapatinib. Instead of binding to the outside of the receptor, lapatinib penetrates the cell membrane and blocks the receptor's signaling mechanism from the inside.
That is incredible, just getting inside the cell to shut it down.
Yeah.
And then there are the angiogenesis inhibitors, like bevacizumab. Let's try to visualize how these work, because the standard explanation of, cutting off the blood supply feels a bit simplistic.
It is a bit simplistic. Think of a growing metastatic tumor as a rogue construction site. As it gets bigger, the cells in the center start suffocating from a lack of oxygen. So the tumor secretes a protein called VEGF.
And what does VEGF do?
It acts like a powerful biochemical SOS signal broadcast into the surrounding healthy tissue. It literally tricks the patient's own body into constructing custom blood vessel highways that route directly into the tumor to feed it.
Oh, wow. So bevacizumab acts as a targeted interceptor for that SOS signal.
Exactly. It binds to the VEGF protein in the bloodstream before it can ever reach the cellular receptors that trigger blood vessel growth. The custom highways never get built and the tumor suffocates.
That is so cool. Let's move to the traditional cytotoxic chemotherapy, though. We know it works by attacking fast-dividing cells, which obviously is the cancer, but also the GI tract and the hair follicles.
Right, the classic side effects.
Yeah, but I want to talk about the delivery mechanisms, because there is a massive clinical myth here. Patients look at an IV bag, dripping chemicals into a vascular access device like a port, and it looks serious. It looks aggressive.
It looks like traditional cancer fighting.
Right, but then the doctor prescribes an oral chemotherapy pill, like capecitabine, to take it home with breakfast. And the automatic assumption is that the pill is just, diet chemo and isn't as strong as the IV.
It is an incredibly pervasive myth, and clinicians spend a lot of time debunking it. The route of administration, whether through a vein or swallowed as a capsule, has zero bearing on the biological potency of the systemic effect.
None at all.
None. An oral agent like capecitabine is a prodrug. It is absorbed through the gut and is enzymatically converted into a highly toxic chemotherapy drug, fluorosil, right at the tumor site. It is fiercely effective.
So you're basically hitting the tumor with a Trojan horse. Speaking of delivery, we really have to talk about intrathecal administration, because this highlights an amazing evolutionary hurdle, the blood-brain barrier.
Oh, the blood-brain barrier is a microscopic, highly selective security checkpoint. The endothelial cells lining the blood vessels in the brain are packed so tightly together that they physically prevent toxins, pathogens, and most large molecules from crossing from the blood into the brain tissue.
It evolved to protect our most vital organ.
Exactly.
But when breast cancer cells manage to slip past it and metastasize into the cerebrospinal fluid, that evolutionary defense becomes a lethal problem, because it locks the IV chemotherapy out.
Right. The systemic drugs circulating in the blood literally bounce off the barrier. So to treat carcinomatous meningitis, the oncology team has to physically bypass the barrier.
How do they do that?
They use a lumbar puncture or surgically implant a specialized reservoir under the scalp to inject the chemotherapy directly into the cerebrospinal fluid, allowing it to wash over the brain and spinal cord.
It's so intense. But that systemic approach, hitting the cancer everywhere, raises a massive biological problem. If these drugs are systemic, they aren't just hitting the cancer. They are hitting every rapidly dividing healthy cell in the patient's body. The collateral damage is profound.
And managing that collateral damage, the toxicity, is arguably 50% of an oncologist's job. If the patient cannot tolerate the therapy cannot extend their life.
Right, so let's look at the bone marrow, specifically myelosuppression. Chemo causes a drop in red blood cells, leading to profound anemia.
Which is often managed by administering synthetic erythropoietin to stimulate red cell production.
Okay, but the truly dangerous side effect is the destruction of white blood cells, specifically neutrophils. And the timing of this is what's really interesting to me. The white blood cell count doesn't drop the minute the chemo enters the vein. It hits its lowest point, the nadir, about 7 to 14 days post-infusion. Why the delay?
It comes down to the natural life cycle of a neutrophil. Chemotherapy generally doesn't destroy the mature circulating white blood cells that are already out fighting infection.
Oh, it doesn't?
No, it destroys the rapidly dividing progenitor cells back in the bone marrow. A mature neutrophil only lives for a few days. So for the first week after chemo, the patient's immune system looks fine on paper.
But once those mature cells die off naturally, there is no replacement army coming from the bone marrow.
Exactly. The factory was bombed a week ago, and you only realize it when the inventory runs out.
Wow. And that nadir window is when a simple fever becomes a life-threatening medical emergency.
It's terrifying. To counteract this, clinicians use cytokines like Neulasta. Administered a day or two after the chemo, it is a chemical messenger that essentially screams at the surviving bone marrow stem cells to rapidly divide and mature.
Flooding the system with new neutrophils to dramatically shorten that dangerous nadir window.
He's got it.
And then you have the neurological damage. Peripheral neuropathy is a notorious side effect of a class of chemo drugs called taxanes. It causes a burning, numb sensation in the hands and feet. But how is the chemo drug actually damaging those specific nerve endings?
Well, taxanes work by disrupting microtubules, which are the structural scaffolding inside a cell. Cancer cells need them to divide. But in a healthy neuron, those microtubules act like tiny railroad tracks.
Transporting things.
Yes, transporting vital proteins from the center of the cell all the way down the long axon to the nerve endings in your fingertips and toes.
So the taxane destroys the railroad tracks.
Exactly. The transport system collapses. The nerve endings literally starve for essential proteins, leading to the misfiring, pain, and numbness that characterize neuropathy.
That is brutal. And we see similar structural damage in mucositis, right? Where the rapidly dividing cells of the GI tract are destroyed, causing incredibly painful mouth sores. I read that it can get so bad it actually ruins a patient's denture fit because the gum tissue physically shrinks from inflammation and rapid weight loss.
It does. It makes simply drinking water an agonizing task.
And beyond the GI tract and nerves, you have severe organ toxicities.
Yeah.
We touched on bone metastases earlier. When those bone lesions rapidly break down skeletal tissue, they dump massive amounts of calcium into the bloodstream, hypercalcemia.
Which is very dangerous.
Right. That excess calcium interferes with the electrical signaling of the heart, causing dangerous arrhythmias and severe neurological confusion. But the drugs themselves can also attack the heart. Both doxorubicin, a traditional chemo, and trastuzumab, the targeted therapy we discussed, carry a significant risk of cardiac toxicity.
You cannot save a patient's lungs if you destroy their heart in the process. Clinicians require baseline and regular ongoing cardiac monitoring for these specific drugs.
And they use MUGA scans for that, right? I've seen that term, but let's not gloss over it. What exactly is an MUG scan doing?
Sure, MUGA stands for Multi-Gated Acquisition Scan. It's a highly precise nuclear medicine test. We draw a small amount of the patient's blood, tag their red blood cells with a safe radioactive tracer called technetium-99 meter, and inject it back in.
Making the blood radioactive.
Safely radioactive, yes. A specialized gamma camera then records a video of those glowing radioactive cells moving through the heart chambers. It allows the cardiologist to calculate the exact ejection fraction.
Which is the percentage of blood the left ventricle pumps out with each beat.
Correct. If that number drops, you have to pause the chemotherapy immediately.
Because you're balancing cardiac failure against tumor progression. It's incredibly high stakes. We also see fluid buildup caused by the tumor itself, like ascites in the abdomen or pleural effusions around the lungs.
Yeah, the metastatic implants irritate the delicate linings of these cavities, causing them to weep fluid constantly. It physically crushes the lung, making it impossible to expand.
The intervention there is mechanical, though, right? A
Yeah.
thoracentesis.
Yes. You insert a needle or a catheter between the ribs and manually drain liters of fluid to let the lung re-expand.
Which brings up a very dangerous psychological trap I see patients fall into regarding toxicity. A patient is suffering terribly from these side effects. They are nauseous, exhausted, dealing with neuropathy and mouth sores, and they think, well, if this drug is making me this sick, it must really be destroying the cancer. Does severe toxicity correlate with tumor shrinkage?
It is a very logical assumption, but there's absolutely zero biological correlation between side effect severity and tumor response. None.
Oh, really? None at all?
None. You can have a patient experiencing agonizing toxicity while their tumor actively grows, or a patient with virtually zero side effects experiencing complete tumor remission.
Because the side effects only measure the damage to healthy cells.
Exactly. The toxicity tells you nothing about how the mutated cancer cells are responding. Clinicians must relentlessly educate patients on this.
Because patients will sometimes hide their side effects, fearing that taking anti-nausea meds or dose-reducing the chemo means they aren't fighting hard enough.
Yes, and aggressive symptom management is mandatory.
It has to be. Let's shift to what happens when standard therapies inevitably fail. Because in metastatic disease, resistance is the rule, not the exception, right? The tumor mutates around the drug. Clinicians have to guide patients through clinical trials and alternative therapies.
Trials are the only way the field moves forward. We start with phase 1, which isn't even looking at efficacy. It's strictly finding the maximum tolerated dose in a tiny cohort of humans.
And phase 2.
Phase 2 starts measuring if the drug actually shrinks the specific tumor type. And phase 3 compares the new drug against the current gold standard in thousands of randomized patients to prove statistical superiority.
There was one specific trial mentioned in the source material that really stopped me in my tracks, the rapid autopsy program.
Oh, it is one of the most profoundly selfless acts a patient can participate in. Patients with terminal disease consent to have their tissues harvested within hours of their passing.
Because normally, researchers are studying early biopsy tissue, right?
Exactly. But the rapid autopsy program allows oncologists to see the end game. They can map exactly how the breast cancer mutated to survive all the therapies and the exact biological pathways it used to migrate to the brain or the liver at the very end.
It offers genomic answers we literally cannot get any other way.
And the patients know it will not save them. They do it entirely to pave the way for the generation coming behind them.
That is heavy, but incredibly powerful. Now, outside of formal trials, patients are inevitably going to research their own solutions. We have to draw a hard line here between complementary and alternative medicine, or SARM.
Right. Complementary is used alongside standard care, so like acupuncture for nausea or mindfulness for anxiety. Alternative medicine is used instead of standard care.
And clinicians must actively warn patients about the dangers of biological-based therapies, right? There's this pervasive fallacy that natural means safe. A patient might start taking massive doses of botanical antioxidant supplements, thinking they are boosting their immune system.
But chemotherapy often relies on generating massive oxidative stress to shatter the DNA of the cancer cells.
Right, so by flooding the system with high-dose antioxidants, the patient might literally be shielding the tumor cells for the chemotherapy's mechanism of action.
Exactly. They are actively fighting the treatment.
So how does a doctor navigate that conversation? A patient brings in a printout for a miracle botanical cure they bought online. If the doctor just dismisses it, they destroy trust.
It requires immense clinical diplomacy. You respect their autonomy, but you demand evidence. You sit down and ask, where is the phase 3 trial for this? How does it metabolize in the liver alongside your chemotherapy?
So you don't dismiss their hope, but you fulfill your oath to protect them from dangerous biological interactions. That balance of hope and reality leads us right to our final area of focus, navigating the end of life. Eventually, the biology of the tumor outpaces the science of the treatments.
And we must immediately clarify palliative care here. Countless patients hear palliative and assume it means hospice or just giving up.
But it's not.
No, palliative care is a specialized discipline focused entirely on symptom relief and stress management. It should absolutely run concurrently with active, life-prolonging chemotherapy from the very first day of the stage 4 diagnosis.
It's about quality of life today, not just in the final weeks. But regarding the timeline of active treatment, the book discusses the concept of a drug holiday. I always think calling it a holiday is a bit of a stretch. It's not exactly a trip to Cabo, it's just giving your bone marrow a desperately needed weekend off.
Yeah, it's a carefully monitored pause. If a patient's scans are completely stable and they have no tumor symptoms, but their neuropathy or fatigue is becoming unbearable, the oncologist might pause treatment to let the healthy tissue recover.
But permanently stopping active treatment is a very different clinical threshold.
It is the hardest decision in oncology. The consensus generally points toward ending active chemotherapy when the toxic burdens of the drugs vastly outweigh the shrinking possibility of benefit.
When does that usually happen?
Clinically, this is heavily considered after 3 successive chemotherapy regimens have completely failed to halt disease progression, and the patient's physical performance status has declined to the point where they are confined to a bed for most of the day.
How does a clinician manage that conversation? You are staring at a patient desperately hoping for a cure, and you have to present the clinical reality of an incurable progression.
You cannot hide behind medical jargon. You cannot use vague words like mass or spot. You must be clinically honest, but you don't strip away hope. You redirect it.
What do you mean by redirect it?
You transition the hope from a cure to hoping for excellent pain control, hoping to make it to a daughter's graduation, hoping for a peaceful transition surrounded by family.
Practically, this is also when clinicians must guide patients to finalize advanced directives while they still have full cognitive capacity. We are talking about a living will, which documents specific medical limits, like establishing a do not resuscitate order or refusing mechanical ventilation.
Yes. And a healthcare proxy, or medical power of attorney. A living will cannot predict every biological scenario. The proxy legally appoints a trusted individual to interpret the patient's values and make real-time medical decisions if the patient becomes incapacitated.
The clinical care really extends to the psychological survival of the family, too. The book mentions a beautiful piece of advice for young mothers facing this transition. They encourage them to buy milestone greeting cards for a sweet 16, a high school graduation, a wedding day, the birth of a first child, and write deeply personal messages in each one to be kept in a safe deposit box.
It directly addresses the profound psychological trauma of absence. Healing at the end of life isn't biological. It is entirely emotional and legacy-driven. It allows the mother's voice and values to actively guide her children decades after she is gone.
It's a remarkable way to maintain presence. Okay, as promised for this medical education deep dive, we are going to do a quick clinical review exercise to see how these concepts connect. Listener, visualize this scenario. You are reviewing the chart of a postmenopausal patient. The rebiopsy confirms estrogen receptor-positive metastatic breast cancer that is isolated entirely to the skeletal system. Based on the biology we've mapped out today, what is the most likely first-line systemic treatment, and what secondary medication must you absolutely initiate alongside it?
Okay, tracing the clinical logic back. Because she is postmenopausal, her estrogen is synthesized by the aromatase enzyme, not the ovaries. Therefore, the first-line systemic treatment is an aromatase inhibitor to block that conversion.
Right.
And because AIs deplete peripheral estrogen and actively cause severe bone density loss, which is especially dangerous given her bone metastases, you must continuously monitor her with DEXA scans and prescribe a bisphosphonate, like zoledronic acid.
To reinforce the bone architecture and prevent pathological fractures.
Def-
Excellent. Seeing how the drug mechanism creates a secondary problem that requires a tertiary intervention is really the essence of clinical mastery. Now, to leave you with one final provocative thought. We talked earlier about the rapid autopsy program researchers harvesting tissue to study how cancer cells mutate and successfully migrate to the brain or the liver at the very end of life. But think about the underlying mechanics of that migration.
It forces us to ask a much larger foundational biological question.
Exactly. What if the ultimate cure for metastatic cancer isn't finding a more reach the liver or the brain? What if the absolute holy grail of molecular oncology is discovering the exact biological switch that prevents the original breast tumor cells from ever leaving the breast tissue in the first place? If they never migrate, the disease fundamentally never becomes stage 4.
If you can chemically lock the embers in the fireplace, the forest never burns.
Exactly. We want to thank you for joining us on this incredibly complex, vital medical journey today. Keep questioning the standard of care, keep digging into the cellular biology behind the protocols, and take this mechanistic knowledge directly into your clinical practice and your studies. Until next time.